Okay, good. Now, the reality of our practice is the following. When you see the patients that go outside the cath lab and you write in your reports, excellent angiographic result. In Belgium, we write beautiful angiographic results. I find that funny. And you get the patient back in your consultation, 1 out of 4, so 25% of them will tell you, well, doctor, thank you for the stent, but I feel the same. And that's a big problem. Basically, we're saying that the effectiveness of our procedure is not 100%. No, it's not. It's about 75% if you look at the data. And when you try to understand why this is the case, and we have been measuring the flow after you have a good angiographic result, you'll be faced with the fact that almost a third of patients leave the cath lab with a suboptimal fractional flow reserve. It's a lot. It's a lot. Now, when you think about this problem, I think it's useful to go back in time and understand where we're coming from to see if we find some light in the work of Andreas Grunsik. This is 50 years ago, where he was performing the first intracoronary pressure measurements and the first intracoronary pressure pullback. So he was basically putting a sensor of pressure in the coronary, making a pullback, and identifying whether there was a focal step in the curve, a focal pressure drop, that could be target for angioplasty 50 years ago. Now what happened? Well, Andreas Grunsik also measured the pressure or the pressure gradient after the procedure to be sure that indeed the treatment was effective. Well, we abandoned that practice for a long time and we started relying on the angiogram, and then we have 50% of patients with residual angina. So we're going back to use physiology today with different tools, with better wires, of course, to try to understand what happens. And we're going to use a couple of animations that will basically show what happened in terms of flow in the coronary artery when we do PCI. And we're going to divide this in the main 2 types of disease. We're going to simplify this, of course, for educational purposes. One that is the focal coronary artery disease, which is very easy to understand. Here we're going to put a pressure wire distal in the coronary. We're going to pull back that wire. The FFR is going to be 0.7. But when the sensor crosses the stenosis, you will see a big step. The same step that Grunsik saw in 79 when he did the first angioplasty. Well, not a surprise, when you put a stent, look what happened to the curve. Complete normalization of the conductance in the vessel. If you want to measure FFR after PCI, you can measure it's going to be high. But the biggest, by far, understanding of physiology today is this one. Let's do the same, in this case, with diffuse coronary artery disease defined by physiology. So we're going to put a pressure wire distally. The FFR is going to be exactly the same, 0.7. We're going to pull back, and despite some stenosis, there is no pressure drop. Okay, don't worry. Let's put a long stent, let's cover the whole plaque. This is what we do. This is a 48 in the proxial AD. We implant the 48. Look at the curve. That's what happens in practice. We have realized that we cannot fix functional diffuse disease with PCI. This was an issue, and to tackle this issue, we have basically developed a metric that has helped us understand how to quantify this, and we call this the PPG. PPG is pullback pressure gradient. Basically, it's a metric that goes from 0 to 1. 0 is diffuse disease, 1 is focal disease, and it's basically based on pressure pullbacks along the vessel. Now, what we have learned from the PPG story? Well, this is basically very important data for us. In the horizontal axis, you have the PPG, low numbers diffuse, high numbers focal, and in the vertical axis is the improvement in flow with PCI, which is the goal of revascularization. Even more, is the definition of revascularization, improvement in flow. And you clearly see here that we are very good restoring flow in patients with focal disease, but we cannot improve flow in patients with diffuse disease. All these are OCT-guided PCI, 5 centers in 4 countries. Now, how good is the information coming from the curve to predict what is going to happen? Extremely good. The area under the curve, this is more than 1,000 patients, is 0.82 of the PPG to predict an optimal revascularization procedures. It's not only about the effectiveness of the procedure that physiology can predict, but it's also about the safety of the procedure. What you have on the slide is basically the rate of periprocedural myocardial infarction in patients with focal and diffuse disease, and you see here that the rate of MI is double in patients with diffuse disease when we do PCI. But let's go what really matters, because someone of you will tell me, post-PCI myocardial infarction, we have to measure troponin, that's not really an endpoint. Okay, this is an endpoint. This is angina post-PCI, basically showing that when we do PCI in patients with high PPG, most of them are free from angina after PCI, and more than half of the patients with diffuse disease will come back to you saying, I feel the same. So we basically have identified a subgroup of patients where PCI is more effective. I will skip the video for the sake of time, but PPG is basically extremely easy to acquire. You just require a pressure pullback maneuver. You can do it with the hand, and then you get the results immediately. So we see PPG as complementing all the physiological index in the past, but not answering the same question. All these indexes, FFR, RFR, FR, doesn't matter. They address the potential presence of ischemia. PPG will tell you something different. PPG will tell you how to manage the disease, what is the likelihood of that patient to improve with PCI. And this is basically a completely new paradigm and a completely new use of physiology, where it's not about, does this patient have ischemia, yes or no? It's about how to treat the patients and basically using a prediction to define the best treatment options. The next question is, well, thank you for telling us that we're very good at focal and bad on diffuse. That was kind of we knew already in our hearts that that was the case. The next question is how to treat diffuse disease. Well, we don't know, okay? And that's basically the next trial that we're going to do, understanding what is the best treatment option. What I can say is that that group of diffuse disease is basically treated with surgery, medical therapy, and PCI. It doesn't matter what you do, apparently. All those patients do worse with any treatment if they have diffuse coronary artery disease. And what you see here is basically the change in angina stratified by PPG and treatment, where the winners are patients that have focal disease and are treated with PCI. So if that is the patient on the table, that's the patient that will really benefit from the procedure. How to approach the other type of, how to deal with diffuse disease? Well, I show preliminary data, but this is still under investigation. Now, the second question is basically, does these patients have worse outcomes than those that are treated with focal versus diffuse disease? Well, post-procedurally, yes. And long-term, it appears that deferring patients with significant lesions from PCI is safe compared to treating those patients with PCI. Now, I'm going to close my presentation with the following. When we started the PPG story, and I need 2 minutes as well, when we started with the PPG, we said, okay, we were focused on diffuse disease, and then I need 3 minutes, maybe 2, but we'll put 3 here. Okay, just give me some bonus. So we started to realize that the composition of the plaque was completely different in the cases that had the big jump and the patients without the jump in the pullback. So we start seeing a connection between plaque composition and physiology. So for the first time, we are basically detecting the type of plaque using physiology. I'm going to show you how. In the horizontal axis, you have different plaque characteristics derived from OCT, lipid-rich plaque, 360, thin fibroma, plaque rupture, etc. And I'm going to stratify that by either focal and diffuse disease. The red, the dark red, is basically focal, and the other one is diffuse. Look at this. Thin cap fibroateromas at lipid-rich plaque more than 360 degrees are almost exclusively seen in patients with focal disease. So focal disease is lipidic, and the opposite is true. Diffuse disease is calcific. It's also not a surprise, but now we have the data to support that statement. And one of the most beautiful data that have come from our lab is the fact that we are now understanding how the translational pressure forces influences the cap thickness in cases with vulnerable plaque. If there is a big gradient, the cap is thinner. If there is a small gradient, the cap is thicker. So what I'm trying to say is that coronary artery disease is not one disease. Coronary artery disease appears to be 2 different entities, one that presents as focal and lipidic and is very good responder to PCI, and one that is diffuse and calcific that respond less good for PCI. A couple of examples just to make this visual. This is a case with a lipidic lesion based on CT. Also, you see the thin cut pheroderma with OCT, high PPG 78 with an FFR of 79. And I'll show you the opposite example, which is a case with diffuse pressure losses in the pullback. PPG is low, and you see here, this is calcific. And both diseases have the same fractional flow reserve value. So we're witnessing now an expansion of the use of physiology, not to detect if the lesion is significant or not. That's not the question. The question is now how to approach the disease, what is best for the patients, and how to predict that our treatment will be effective in terms of improvement in symptoms. Thank you very much for your attention.